Respected professors of the orthopedics department of the Siddhartha Medical College and other respected dignitaries from outside the college, and my junior colleagues of orthopedics department and the postgraduates, a very good morning to you all. So before we start with the anatomy of the shoulder joint, which is it's a very vast and interesting subject, we should know the evolution of the upper limb. Evolution of the upper limb itself is again an interesting subject. If you start with the evolution in the vertebrates, and this human upper limb evolution has taken a few 100 million years, we suppose, and the vertebrates you can compare, starting some in the beginning they are jawless, then they are limbless, and all these adaptations of this limb girdles and the limbs, and lastly in the humans, the evolutionaries, they are thinking that it has taken about few 100 million years. And what is the function of the human upper limb? Any of the postgraduates? Human upper limb, I am asking in comparison to the human lower limb, or in comparison with the other vertebrates, other lower animals. If you see, it is then only we can understand how the shoulder joint is modified for this evolution. So if you see this human upper limb, it has totally lost its locomotor function, and it has freed itself, except in sometimes when we move towards some to grasp some immovable object, except few times. So the human upper limb has freed its locomotor function, and its main function, if you see, it is mainly for grasping, load carriage, manipulation. So all these functions of the human upper limb has modified this upper limb into a very different evolution. So then if you understand that human upper limb function, then what are the modifications between the human upper limb and human lower limb, then you can understand the shoulder joint, which itself is a very interesting subject, and it is not, the time will not be sufficient within to tell 15 to 20 minutes. I will tell only what is relevant for this. So if you see this shoulder dislocation, so which position the shoulder dislocation is common, I think the postgraduates will be knowing. Which position? Anterior or inferior? Inferior. Inferior, that reason also we have to know. Traumatic frequent dislocations will be anterior, but the most weak and the point of the shoulder joint is inferior, and the dislocation is subglenoid. So to understand this, we have to know what is this cause for this dislocation, what is the problem in the inferior side of the shoulder joint also we have to know. So as I was telling, the human upper limb has freed itself. We can reach above the head also to reach the ceiling. So that is possible because of the shoulder joint and shoulder girdle joints. So it is very interesting. This human upper limb has evolved so much, which we can raise the upper limb above the head, abduction of shoulder joint. All this free movement, that is the very important point in the upper limb, free movement to grasp anything at any position, that is the major function. So for this, the shoulder joint and shoulder girdle joints have evolved and helped, and they are helping. So we have to understand, so how this is happening. What is the difference between the upper limb girdle and the lower limb girdle? Lower limb girdle is mainly for that postural and locomotor, heavily built, and it is having stability. If you see again in contrast to this, if you see the Pectoral girdle which is made of clavicle and scapula, pelvic girdle which is made of the hip bone. There are so many important differences we have to know. So this pectoral girdle is not having any articulation with the vertebral column at all. And the pelvic girdle is massively built and it is articulating with the sacrum. So that is the main difference between the two limb girdles, which is helping our shoulder joint and shoulder girdle movements possible as far as possible to any extent. So that is what is the only articulation of this limb pectoral girdle with the axial skeleton is only the sternoclavicular joint. That is the one important point we have to know. And the scapula is simply suspended from the vertebral column by the muscles like rhomboides major and minor and levator scapulae and again over the trapezius. So these muscles are simply attaching this scapula to the vertebral column and no direct ventral articulation. So as we have introduced the pectoral girdle and pelvic girdle, so the shoulder joint is the shallow joint. So that is again, what are the causes for these free movements in the shoulder joint is, it is a shallow joint and lax capsule that allows the free movements. So what is the necessity? It has evolved. So how then it is supported, we have to know. So it is having shallow articular surfaces and lax fibrous capsule, which is very much helping in our everyday activities in grasping, load carriage, everything. Then we should think how it is supported. That's the important aspect of the shoulder joint. So as the shoulder joint movements cannot be separated always from shoulder girdle joints, which are the acromioclavicular, and I think okay. So the shoulder girdle joints, I can here you can see in this acromioclavicular and sternoclavicular joints. These joints always move the humerus. Acromioclavicular will move the scapula. Scapula will always move the humerus. So even though we separately tell the joints as separate, but you have to understand in the last degrees of abduction we can't separate the girdle movements and the shoulder movements. They tell that for every abduction in every 15 degree, 10 degrees contributed by shoulder joint and 5 degrees contributed by the shoulder girdle joint. So that is the important functional aspect of the shoulder and the shoulder girdle joints. So you can appreciate in this acromioclavicular joint and the glenohumeral joint, which is the shoulder joint. So just about that we have the acromioclavicular joint. So as I was telling, whatever these movements we can't separate at one stage. So we can now start with the shoulder joint itself, which I will fastly cover in 5 to 10 minutes. You can appreciate that shoulder joint, which is having the shallow articular surfaces. You can appreciate roughly hemispherical humerus head and shallow scapular glenoid fossa. If you see, even though we tell this as spheroidal, that is the other name for the ball and socket joint, but the articular surfaces are really not spheroids but ovoids. If you see in the hip joint, they are really spheroidal in shape, but here they are typically ovoid in shape. So you can see how much is this humeral head is over than the shallow glenoid articulating surface. So that is the very important point for this. At any point of any movement, the humeral head is not able to accommodate in the glenoid fossa at any moment and at any time. So that is the cause for this free movement in the shoulder joint, which is very necessary in our adoption. So these articular surfaces are really somewhat again made deepened by the glenoid and labrum, and as usual at any synovial joint they are covered by the hyaline articular cartilage. So this is about the articular surfaces we have covered. Now we will see the ligaments, the shoulder joint ligaments. So shoulder joint ligaments, first I have to tell the fibrous capsule. You can see the fibrous capsule. I have kept the side by side the articular surfaces and the capsule. You can see this capsule is loose and it is extending more than the articular surfaces. You can appreciate it has come to the even encroached the coracoid process. That's why it is having the long head of biceps tendon inside the shoulder joint. So this is that medial attachment. You can appreciate it has not only involved the glenoidal margins, it has moved elaborately to encroach the coracoid process and to envelop in its long head of biceps. And on laterally, if you see, even it is coming up to the anatomical neck of the humerus. If you see in the inframedial part, again it is extending slightly to the shaft of the humerus. As I was telling repeatedly, this is the loose fibrous capsule covered inside by the synovial membrane. So that is the very important cause for this free mobility of the shoulder. So we are now stressing on free mobility. 2 points I have added, which is the main factor is shallow articular surfaces and loose fibrous capsule. So now we have to again see which is how this is supported. You have to ask if it is like this, what is the support for this? So you can see this capsule is so lax that can be even we can distract this for 2 to 3 centimeters that can be distracted. So I was repeatedly telling loose fibrous capsule. It is supported by our rotator cuff. You can see in the 2 pictures. Above is supraspinatus and so this is the above is the supraspinatus. So this is the shoulder joint, above by the supraspinatus, in front by the subscapularis and behind by the infraspinatus and teres minor. So this suprascapular, we have to know this, just above the shoulder joint we have a coracoacromial arch. Below the coracoacromial arch, the supraspinatus tendon is coming for insertion. This is the very important cause for the supraspinatus tendinitis. We have to understand that it is passing just below, and in every abduction the supraspinatus helps in 15 degree of abduction, which we will always keep in 15 degree of abduction. So the supraspinatus tendon is always getting its friction over the coracoacromial arch. So this is the rotator cuff. So this fibrous capsule needs its support from all these 4 tendons, which is forming the musculotendinous cuff or the rotator cuff. So if you see the capsule, it has 2 openings. We can see here, this is below the superior glenohumeral ligament, 1 opening, that is the below the coracoid process, that is communicating with the in front of subscapularis tendon, and another opening you can nicely see here, the long head of biceps has to come out. So there is another capsule, another opening. So first fibrous capsule and synovial membrane. Only main important ligament apart from fibrous capsule is our glenohumeral ligaments. This we can see as your orthopedic PGs. You can appreciate, even though this picture is given as if this is thickening in the outer side, but it is best visible from the inner side of the shoulder joint. 3 glenohumeral ligaments, you can see superior, middle and inferior. So the superior, it is taking from the uppermost margin of the glenoid, even reaching the coracoid process, and it is reaching the anatomical, I can explain here. So from this part, glenoid margin and coracoid process, the superior is reaching between the greater tubercle and articular surface like this. So it is reaching like this. If you see the middle and inferior, so middle is attached to the anatomical neck and inferior is again attached to the just below the anatomical neck of the humerus. So if you see this, in this inferior is the very strongest in the 3, and these 3 glenohumeral ligaments are the only ligaments which are the main support for this fibrous capsule. So next ligament, coracohumeral ligament, it supports the joints from above. So it is attached to the coracoid process to the humerus, greater tubercle of the humerus. So it is the support from the upper part of the fibrous capsule. As we told, glenohumeral ligaments are mainly in the front of the fibrous capsule. This coracohumeral ligament is in the upper part. So these are the ligaments. Again, we are going to conclude the ligaments. Fibrous capsule. This is the coracohumeral ligament. You can appreciate it is supporting the shoulder joint from above. And one interesting this ligament, transverse humeral ligament. Even though we described this under the shoulder joint, you can appreciate it is not at all related to the shoulder joint articular surfaces. It is just bridging the long head of the biceps tendon between the greater and the lesser tubercles. So this completes the ligaments of the shoulder joint, fibrous capsule and synovial membrane, glenoidal labrum which is already described with articular surfaces, glenohumeral ligament, coracohumeral ligament and transverse humeral ligament. So we will see quickly the relations. So the PGs or anyone should appreciate the relations of the shoulder joint is mainly our deltoid. Deltoid covers the joint anteriorly, laterally and behind also. Then you have to understand this deltoid is the important mover of the shoulder joint. So that is the main relation of the shoulder joint. Again, other relations we can see you have in this picture it is missing. We have to draw the deltoid like this, outside all these other muscles we have to. So what are the relations? Above is supraspinatus, in front is subscapularis and behind is infraspinatus and teres minor. The students can remember these are the four muscles we are telling repeatedly. They are forming the musculotendinous cuff. They are because they are the relations for the shoulder joint in all the other directions. So they are going to naturally form the rotator cuff. You can appreciate here in the lower part there is no direct support for the shoulder joint. The long head of triceps is separated from by these two structures. So that is what I was telling. This is the weakest point in this infromedial part which is not having any direct muscular support. So if you see some small, so many bursa are described in anatomy textbooks. So I want to tell few bursa. So this which is communicating, which is not communicating, we have to understand. This bursa, subscapular bursa between the subscapular is front and the capsule is communicating. This subacromial bursa between the deltoid and the fibrous capsule is not communicating, but it is the largest bursa. So little about the vessels. The vessels will be the branches of axillary vessels. So they are and some branches of the subclavian. And the nerves around it is naturally axillary nerve and suprascapular nerve. So to tell the movements, we will play this.
Biomechanics and kinesiology. I use biomechanics in my everyday practice and believe that it compiles the fundamental knowledge of the movement science. So grab your pens and pencils and settle into these questions. I've summarized the information from a variety of articles and books, but the main sources were the text by Hello, in this video we will examine glenohumeral joint arthrokinematics. Glenohumeral joint possesses 3 degrees of freedom, meaning it moves in all 3 cardinal planes. It moves in the sagittal plane for flexion and extension, the frontal plane for abduction and adduction, and the transverse plane for internal and external rotation. Let's examine the sagittal plane first. Here, humerus spins on top of the glenoid. With flexion, humerus spins posterior. Observe the greater tubercle moves posterior. With extension, humerus spins anterior. Observe the greater tubercle move anterior. Now, the frontal plane. During glenohumeral abduction, humerus rolls superior and glides inferior. During glenohumeral adduction, humerus rolls inferior and glides superior. And last but not least, the transverse plane. During glenohumeral internal rotation, humerus rolls anterior and glides posterior. During glenohumeral external rotation, humerus rolls posterior and glides anterior. Now, let's examine a clinical scenario to which we can apply the arthrokinematics we just learned. Sally is a 24-year-old college student complaining of a left shoulder pain since about 3 months ago without any mechanism of injury. All range of motion was found to be within normal limits, except abduction was limited to 150 degrees and external rotation was limited to 50 degrees. Question: which direction would you mobilize the humerus? 1, if you wanted to regain abduction range of motion, and 2, if you wanted to regain external rotation range of motion. Okay, let's answer this. Remember, you always mobilize in the direction of the joint's glide. So, if you wanted to regain abduction movement, you need to mobilize humerus inferior. If you wanted to regain external rotation movement, you need to mobilize the humerus anterior. Here's Sally. She's doing so much better thanks to you. She has finally regained her full range of motion. I hope this video was helpful. If it was, give it a like and subscribe.
So instead of explaining the movements with my own explanations, I thought of giving a video, and I think it should be helpful for you in any little way. So the movements, muscle causing movements, with that the topic will be over. So all these movements, what are the muscles which cause these movements? We have to understand what are the muscles which are around. Still now we are telling rotator cuff and deltoid is covering. So this deltoid which covers, you have to understand all are which are converging towards the humerus. They are going to help the movements. Main muscle is this deltoid, which is the powerful abductor of the shoulder joint from 15 degree to 90 degree. First 15 degrees by supraspinal tendon, and after 90 degree, it is not at all a pure shoulder joint movement. The shoulder girdle joints have come into action. By that only we are reaching to 180 degree abduction. So the next important muscle which are again causing this flexion is pectoral is major. You can appreciate how they are taking origin from this sternum and clavicle attached to the humerus, how they can pull the humerus to the front. So that is called flexion. And this is the muscle which is the very interesting muscle. I like this muscle, latissimus dorsi. This is the only one muscle which is connecting the two girdles, a pectoral girdle and the pelvic girdle, and it is very interesting to start from the hip bone and it is inserted to the humerus. Other small muscles around the shoulder joint, so that is the teres major, which is very helpful. So we have to remember these muscles are going to cause anyway all the movements, which I need not tell you. I think for just information I have put. All these movements are caused by the muscles around, which we have seen elaborately. And I like always this abduction movement, which is caused by this powerful deltoid and added with that scapulohumeral rhythm. So apart from 90 degree, after 90 degree, shoulder girdle is coming and helping this. So that we are elevating the students should remember, we don't have elevation movement in the shoulder joint. So that elevation, depression, everything which is the movement of the shoulder girdle, acromio clavicular and sternoclavicular, together they are causing elevation and depression of the shoulder joint and protraction and retraction. These are not the movements of the shoulder joint, as we have already seen what are the movements in the real shoulder joint. So this flexion, elevation, depression, protraction, retraction, which are caused by girdle movements. So if you see after 90 degree of abduction, we are elevating. So that is helped by shoulder girdles, and that is acromio clavicular. Whenever acromio clavicular elevate, the sternoclavicular depress. Whenever the sternoclavicular elevate, acromio clavicular depress. So like this two girdle joints are helping in each other. So that is causing, and I like the movement always abduction of the upper limb, which is caused by so different, as we started in the beginning, evolution of the upper limb, and which we have now explained. So this is again in one diagram how we can explain all the muscles moving on the shoulder joint. So this is how the shoulder joint, very interesting joint, having the shallow articular surfaces and loose fibrous capsule supported by all the muscles around, and skeletally this joint is very weak and supported by the joints around, which is helping in the very vast movements of the shoulder joint, which is the problem for the shoulder joint. Dislocation, which is the common clinical condition, which it has to pay for its free movement, which it has adapted. Any doubts for you in this? I can clarify. Thank you, sir, Shyam sir and Srinivas sir and orthopedic department for giving me this wonderful opportunity in the fresh morning of Sunday.